So good afternoon, everyone. Like we already said, I'm aware that everyone has been at this for some time, so we'll make this as pleasant as possible. I'd like to thank all of you for taking our time out of your practices and days to listen to a myriad of lectures for hours and hours. I really appreciate it, and it's a great honor to be through to the Continental round of the MegaGen Megamind. For those of you that I haven't had the privilege of meeting, my name is Rhoodie Garrana, and I'm a periodontist from Johannesburg, South Africa. And it's a great honor to share what we do here with the rest of the world. So what I'd like to talk to you about today is predictability and reproducibility. With regards to implant dentistry and the protocols that we use in our practice. A large part of what we do depends on the predictability and reproducibility. It doesn't help if there's a technique or a procedure that works 1 in every 10 cases. I want to be able to carry out a case predictably and make it reproducible for every patient in the practice. To demonstrate the predictability and reproducibility, I'd like to share with you a case that I've been working on. It was a middle-aged female that presented to my office with a tooth 1-1 that exhibited radiographic signs of external inflammatory resorption, cervical resorption on the tooth. When she came, she was devastated. She has a relatively virgin dentition. She's got a few restorations here and there, but she was devastated at the fact that she had external cervical resorption on this tooth, and we had to come up with a game plan with regards to what we could offer her in terms of management. So she has a thin biotype and triangular shaped teeth, which makes this a challenging case when considering implants in the anterior aesthetic zone. I classified her as a class 1B radial tooth position, according to Gluckman's CBCT analysis of radial root positions. And this is significant because I find it's one of the most important things we can do when we start assessing cases, is try and understand the field that we're working in before we blindly apply treatment protocols to these patients. And when considering an implant case, if we were going to place an implant in this case, when considering the radial tooth position, we need to understand that for an immediate situation, less than 50% of the implant will be embedded in native bone. If we were going to look at an immediate load type of situation, and less than 50% of bone being around the implant at the time of placement is not ideal. If you look at the work done by Joseph Kahn and the likes, we would like at least 50% of the implant to be embedded in native bone when considering an immediate situation. Obviously, Ostel readings taken at the time of placement are a decisive factor, but this is something that's certainly going to play on my mind. So we're already starting off on a little bit of a back foot if we were looking at removing the tooth and placing an implant. Because of the thin biotype, I've got several options available to me. Do we go with a socket shield? Do we extract the tooth in its entirety and do dual zone technique, as the Swiss recommend? Do we go with dual zone and the sandwich technique as the Swiss recommend, or do we go with dual zone therapy? Socket shield, obviously a firm favorite of mine in cases where we want to maintain the surrounding tissues. So I decided to remove the crown using a very, very thin fissure burr supplied in my socket shield armamentarium, making sure that we are not damaging the soft tissue, applying slight lateral force on the crown. And so I can remove the crown at the level of the gingiva so I can get a good look at what's happening. And we can see clear signs of the resorptive tissue and the granulation tissue inside the canal. Not a lot of sound tooth structure left on the inside of that tooth. I then continue with my fissure burrs in my kit to section the tooth, and I'm trying to see if I've got enough sound tooth structure here to perform a socket shield. Obviously using radiographs to assess my depth and my alignment so that I'm not off, but I want to see if I can remove and keep enough tooth structure and remove enough of the palatal root to get an effective shield in place. So this was us having removed the palatal root segment, and you can see the destruction of the tooth structures quite significant when you're looking at it from this angle. And we have a retained buccal root left in place. We then go through the protocol, reducing the root and thinning out the root and giving it some curvature to make space for the implant. We want to create as much space as possible between the implant and the shield. It was at this time, though, that I decided that I wasn't going to have enough bone to anchor the implant into successfully. So I changed my plan during surgery, and I grafted the socket with a Glocker technique, as was described by Marcus Glocker in 2014 as a form of ridge preservation. And I think that the benefit of this is largely underreported and underrated, because, you know, if you can have a fully healed ridge and come back and place the implant into a healed ridge, and the implant is circumferentially encased in bone, the chances of success are much higher, especially when you don't have a lot of palatal bone to engage that implant into. So I grafted the case and I let it heal up. The problem was, how do I temporize this patient? Because the benefits of immediate placement and immediate load allows me to preserve the soft tissue architecture and provide some sort of a provisional for the patient during the healing period. In the case where we're not going to be placing immediately, we need some type of a solution that we can give the patient whilst we are awaiting healing. So I took the tooth that we had sectioned off, and I added some composite, and I used the pencil to mark off where I wanted my zenith point to be. And these photos are very rough of when I first started. And then I bonded the crown back to the adjacent teeth in place at the ideal position, highly polished composite, to stimulate hemidesmosomal attachment to that area. Is it a perfect provisional? No, but I believe that a removable partial denture would destroy the soft tissue architecture there over time. It's not ideal. This is the best I could give them in this situation. And so making sure to copy the architecture of the soft tissue from the contralateral side. 4 months later, we opened up the site, and we are pleased to see that there is solid bone, vascular bone in that area. We can see the shield, and we can see bone on the buccal part of that shield. So we've achieved a functional ankylosis of that shield, and we've maintained 100% of the volume that we set out to maintain. When raising that flap, I make sure that it's low trauma as possible. I then placed a Megagen AnyRidge implant into that site, suturing the papilla together. And now, at this stage, my Ostel reading is a lot higher, and having the implant encased in bone, I've got a much better chance of success. And so I can think about doing an immediate load restoration at this stage. At this point, it's important to look at the work done by Ramon Gomez Meda and his team, looking at what they call the aesthetic biological contour of a tooth, where we have the aesthetic zone, the biologic zone, and connective tissue zone. Hansu spoke about this previously, where she talks about critical and subcritical contours, and it's effectively the same principle, except a more up-to-date paper where they talk about the aesthetic and the biologic zone. So the aesthetic zone responsible for the gingival margin and where the gingival margin is going to sit, and this is the 1 millimeter of prosthetics or prosthesis that is sitting below the gingiva. And then once you get to the biologic zone, having it as concave as possible to allow for the infill of biologic tissue rather than prosthetics. And then the connective tissue zone, obviously also important, adding to that insulating cuff of tissue that is going to ultimately protect the implant through its life. So my lab is already very au fait with developing provisional restorations according to this protocol. We want to make sure that we adhere to these zones so that we can get optimal soft tissue healing, and we can control the soft tissue where we want it to be. After healing with the provisional, we can see clearly here, according to Ramon Gomez Meda's paper, we can see the aesthetic zone, the biological zone, and the connective tissue zone very nicely. And this kind of just reiterates that we've achieved what we wanted to. If you have a look at the time of placement of the provisional, which is 24 hours after implant placement, if we use a reference and we can see where the gingival margin is compared to after healing, we can see that there's been a coronal creep of the soft tissue, and this is very thin soft tissue, but we can see that there's been a coronal creep of this tissue. Why? Primarily because we have volume, we have bone, and we have followed the principles of ideal prosthetic crown contours. So we can control where we want the soft tissue to be. So we're very pleased that at 4 months, we've seen an optimal healing in this case. Once removing that crown, one can argue, should we be removing crowns and replacing crowns on and off all the time, breaking hemidesmosomal attachment? Potentially not. However, I did remove the crown at this point, and we can see a beautiful S-line curve, and we can see that the soft tissue filling in that S-line curve there very, very nicely. And so this is just a mirrored image showing the case on your left-hand side before, and a mirror of the implant crown on the right. And once again, I'm a periodontist. I don't do any final restorations. I send them back to their clinicians for restoration, but these are my provisional. So this is a provisional that the patient kept for 6 months. And then we can see after 6 months how beautifully the soft tissue is healed around that crown. And I think at this stage, the patient and the restorative clinician has a much easier task of restoring, and our job here is done. Thank you.